Yeah, the next speaker is the moderator himself, Dr. Khalid Al Thani. He is a senior consultant from Bahrain. He is very active in the research area of the Gulf. He is going to talk about the management of dyslipidemia and post-PCI double therapy or triple therapy. Please, Khalid.
Thank you, Dr. Mustafa. Let's do this quick, and it's a specific topic, specific target population that I'm going to go through. Basically, the cardiovascular disease is the leading cause of death in the whole Gulf, by the way. I kept this for the UAE because we are now staying in Dubai. So the total of 40% of total death in UAE is due to cardiovascular diseases. So it's a big burden to the healthcare system here in the Gulf, and also it's a big health issue all over the world. When you look specifically at the atherosclerotic cardiovascular disease, it's driven by elevated LDL and develops and progression over time. So we all know about the atheroma and the thin cap and the thick cap and the plaque rupture at the end of the day. So unstable or ruptured plaques occludes blood flow and increase the risk of the cardiovascular events. Early intervention is mandated by such thing. Look at like patients who have had a cardiovascular event or at increased risk of recurrent cardiovascular event. We treat the patient, and then when we come to the follow-up for this, like after a mine or after a stroke, the risk of another cardiovascular event within 4 years is 1 in 3. So still, there is some sort of a gap that we need to fill, and we don't want this patient to come back to us in the clinic or like in the hospital to be admitted. I love this slide because this slide shows you that the elevated lipids have the greatest impact on MI risk. So you have the smoking, you have fruit, vegetables, lack of exercise, alcohol, all these risk factors, but elevated lipids is, I would say, it has the greatest impact. Look next to the lipid, psychosocial stresses. And I don't think all of us, we are excluded from psychosocial stresses. And we see it a lot, and when the patient comes to the clinic, that the social, it comes hand in hand with the smoking, but lipids surpass it. All of us, we know that the lower LDL is better. Over 25 years of lipid lowering trials consistently demonstrated that every 40 milligram per deciliter, or which is 1 millimole per deciliter, decreases in LDL, decreases the relative risk of cardiovascular event by 20 to 25%. So 1 millimole. So if you decrease it by 2, you have double, like 40%. So think about it. You need to try to do your best in lowering the LDL level for the patient. So there is an unmet needs for the LDL lowering when statins won't do. There is a 67% of patients receiving lipid lowering drug for secondary prevention are not controlled. So we have a gap. It's difficult, especially, I don't want to say like in other regions, but here in the Gulf, there was some type of lifestyle, the type of food is available in the region plays a major role here. This is, when you try to intensify the statin therapy to provide additional cardiovascular reduction, there is still residual cardiovascular risk, and we all know about the residual cardiovascular. It's remain like the major, I would say, reason that's why the patient comes back to you with another cardiovascular event. So we learned that lipid-lowering therapies have evolved over the years, and to achieve the lower the LDL cholesterol, the better the outcomes. So, and we know it from the latest IMPROVE-IT and the 4-year trials. The level of the LDL recommended by guidelines have decreased over time. That's another thing we learned over the last few years. The guidelines have updated itself to reflect this, and we know it. I mean, half of, I don't know, all of us, I don't think half of the audience here, we started repeating the lower is better. This is the recommended 2019 treatment goals for the LDL lowering therapy. We have the high risk, very high risk, and moderate, and then the lower risk, and we started going with the lower level. Now, it's difficult, and I know it's difficult if you are there sitting in a busy, like governmental hospital or like a busy private sector. It will be difficult for you to monitor these patients and reach the target that you want for them. So our population is post-MI and post-PCI, and these are considered the high-risk patient. The tools for the lipid-lowering therapies, we have a lot of tools. Okay, the patient requiring additional treatment are typically high-risk patients or those with very high risk, as I mentioned. The LDL goal is still not achieved with like single pill statin. You have to add other things to achieve the level that you would love to have this patient reach. The plasma LDL concentration are associated with the dose-dependent increase in the risk of cardiovascular atherosclerotic disease. And we know it with all the meta-analysis that reducing plasma LDL level with a statin leads to dose-dependent reduction in the risk of atherosclerotic disease. And this is proportional to the absolute magnitude of the reduction in the achieved LDL. So we know it, but how to achieve it? What about the analysis of statin and non-statin trials? The absolute LDL cholesterol lowering was correlated with relative risk reduction in cardiovascular event. So that's another thing. It's not only related to statin, also non-statin therapy. This is 2016 and 2019, okay? And you can see that the changes in the cutoff and the changes in the adding the secondary cardiovascular event within 2 years, that we started to be more aggressive in trying to lowering the LDL level. So this is 2019. We'll go stepwise. You have the step one. So you have to determine the global cardiovascular risk. And because today's lecture is tailored for a very high patient, a very high risk patient, which is post-MI, ACS patient. So once you document it, this is your patient, and then you go through the guidelines to the management, which is the baseline level. You have to determine your baseline level during the index event. And then you start, define your treatment goal for this patient. So, which has a class 1 level, by the way, level A. So you need to start high intensity statin for this patient. Low intensity or more, it's not recommended anymore for these patients. So start high with these patients. And once you have an LDL goal reached, if yes, you just follow up these patients annually. Okay. If no, then you have to add ezetimibe. And if still that you are not achieving your goal, then you go to the next step by adding PCSK9 inhibitor for this patient. Now, for the post-MI patient, a PCI patient, you have to follow these patients after 4 to 6 weeks to assess the LDL level for these patients. Now, it's a stepwise strategy. It does not work in the unstable patient, these unstable, because subtotal prescription will not be corrected. There is around 16% were treated with high intensity at discharge, and 27% during follow-up. Most patients continue the discharge prescription. So there is some sort of inertia, that the doctors or basically the follow-up for this patient. You are concentrating on other issues regarding the situation, maybe the diabetes, but you have to have a closer look at the LDL level for these patients. So there is around 50% of patients discontinue their statin within less than 2 years. Yes, there is. And basically because some of them, they feel the side effect or non-compliance, basically, despite the fact it's a tablet that they take in the evening. I notice a lot of patients, their problem is having, instead of taking one tablet, in some hospitals here in the Gulf, they have 20 milligram tablets, so they have to take 4 at night, so to actually to reach 80 milligram of atorvastatin or simvastatin. So it is, they will come to you why I should take 4 tablets. So that's the guidelines. So you have to step one, high potency statin plus ezetimibe, which is the #1 approach in patients with very high risk. And then step 2, you escalate it to the starting the PCSK inhibitors. When you look at the latest trial that came out, the combination lipid-lowering therapy as first-line strategy in very high-risk patients, because when to start? Like, shall I start as early as should be? Yes, you have to start like as early as it should be, because the conclusion for the Dr. Ray, we should move away from high-intensity statin treatment and the weight and watch paradigm, and instead start treating all very high risk and extremely very high risk patients with combination therapy as the basic standard of care. And all of us, we know now we have like a combination tablet you can start for these patients as early as index admission for these patients. So this is a kind of simplified treatment algorithm proposed, probably is going to be reflected soon for these patients, because to start as early as it should be by having the combination therapy instead of like stepwise starting one by one. What is the expected clinical benefit of LDL lowering? There you go. I think all of us, we know it, starting from the moderate intensity statin to having 3 combination triple therapy or like a double therapy, huge, I would say, average LDL cholesterol reduction. What about plaque regression? Yes, it is there. The study from the OCT and the intravascular ultrasound, it shows that there is huge, plaque regression when you start and hit hard for these patients. So in summary, dyslipidemia is a major health condition and pose a challenge to the GCC healthcare system. We are moving from high-intensity statin to a high-intensity LDL lowering approach. Stepwise medical therapy approach and close follow-up for these patients is mandatory. You have to start, hit hard in the beginning, and then you have to follow these patients after 4 to 6 weeks. I would recommend for big hospital to have hyperlipidemia clinic to follow up these patients. And in the coming future, we're going to see injectable long-term hyperlipidemia medication and also hypertriglycemia medication. It is like an uprising approach of treatment for these patients too. Thank you.
Thank you very much, Dr. Khalid. It is very comprehensive talk about dyslipidemia and lowering the LDL. There is 2 urgent questions for me. Number 1, we have a lot of risk factor for atherosclerosis, dyslipidemia among all of the important of them. Is there a risk or causal correlation by what percentage the dyslipidemia or high LDL contribute to the manifestation of atherosclerosis in the presence of control of other factors?
To name something specific with the cholesterol, I
Well,
guess.
Is it the most important risk factors compared to the smoking or hypertension and diabetes?
It's one of the major ones that comes, because I showed all of them across the board. Our patient population is very difficult because they don't have only hyperlipidemia. They do have bad diabetes control, bad blood pressure control. So when you see them in the clinic, especially old mamas, old babas, you're gonna have difficult, convince them to take all these tablets. And to tell you the truth, it's polypharmacy is very difficult. You need to have them, because not all of the hospitals we have a clinical pharmacist to review with them all the medicine. I noticed this. I may say it. In Saudi Arabia, because you have different healthcare system provider. And you will find all baba, old mamas, coming to your clinic, and they are taking from each hospital, because her son works in the National Guard, the other son works in the military. It's a polypharmacy, very difficult, unless if you have go through them. And not only this, they are not taking the tablets. So their diabetes is totally it's another risk factor with other problems. They don't come with cardiovascular, they come with the peripheral vascular disease, carotid disease, stroke. So
Thank you very much. I guess that's very important. I am from those supporters for the combination therapy from the beginning, because, starting with the 40 or 20 milligram of statin, then you build it up. The rule of 6 is there. You might gain only 6%, which is nothing in front of the high risk and very high risk patients with the underlying coronary artery disease. So we have to be aggressive from the start. And there is a formula, in fact, to try to calculate how much you are going to gain by uses of the statin additional to the ezetimibe and PCSK9. However, the problem is that the compliance is an issue, and we have to emphasize among all of our patients. And we have to start it in the hospital, particularly after PCI, as you have said, because that would raise the compliance of the patient. And it's become very important to emphasize this. Some people think that the non-HDL or non-HDL cholesterol in general, with addition, for example, of hypertriglyceridemia, one should keep in mind to look into the totality of the lipid disorders.
So to tell you the truth, I wanted to touch base on this lecture because of the limitation of the time regarding the HDL, regarding the lipoprotein little a, the unresidual for the VLDL and the intermediate density cholesterol. I mean, I did not touch base on this during the lecture, but you have to look into it because we know it here in the region. Lipoprotein little a is very high. It's like,
Professor Hassan is the last question. Because this man who's standing for a while.
Hi. It has been a great presentation because you moved away a little bit from the ESC guideline of 2019. I think the ESC guidelines have become 3 years old, and the seminal work which has been done by Kaushik Ray and John Castelline, it's really very different from the ESC guidelines. And after the ESC guidelines came, I just wish to bring it a little bit in the notice. Dr. Colombo is here. The Italian consensus report was published in European Journal of the, I think, the preventive diseases, in which they said that anybody who is having 160 and diabetes, 160 of the LDL cholesterol plus diabetes, he should be discharged on dual therapy from the very beginning. After that, the French consensus report was given, in which they said anybody who is having the LDL cholesterol above 100 should be discharged on dual therapy from the very beginning. And this year, the Lipid Association of the India also published its own guidelines for the very high-risk patients, the acute coronary syndrome, and which, I think the patients from the Indian subcontinent, which constitute roughly about 1.7 to 1.8 billion patients, for them, they have recommended from the research area, you can start with the maximal intensity statin therapy, 80 milligram atorvastatin plus ezetimibe. And then at the 6 weeks, you see how the patient is doing. If it is not controlled at PCSK9, if it is controlled, forget it. So, it is something like, and one of your slides was really great, in which it showed that the IMPROVE IT trial, it is at a lower level than even in the 4-year trial.
Thank you very much. We have short of time.
I think I touched base regarding this, regarding starting and then after 4 to 6 weeks with the recent, probably the new guidelines is going to be reflected to start, hit hard and then like within 4 to 6 weeks to follow up the patient.
Professor Hassan.
Thank you. I think in an ideal world, and there's no restraint on the cost, I would start with the PCSK9. I think they have shown to have outcome benefit, compliance, no issue. The problem is costing. And I think then you add a little bit of statin, because compliance, as you said, is a major issue. And patient and the social media is not helping us at all.
Yeah, I think that's a different opinion. The recommendation by the guideline is totally different. Back to the moderator for the take.